Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be discussing some of the evidence behind our management of early-stage non-small cell lung cancer. I'd like to start by talking about some of the important trials that we should know regarding surgery for early stage non-small cell lung cancer, and then we'll get into the SBRT data and kind of the evolution of how we've used SBRT for early stage non-small cell lung cancer. And along the way, I'll also kind of add in important trials that relate to systemic therapy and how we combine that with local therapy. So starting with surgery, if you recall from the overview talk, we mentioned that lobectomy is really considered gold standard for early stage non-small cell lung cancer. However, there is a recent study that tells us that for tumors that are less than 2 centimeters in size, a sublobar resection, so either a wedge resection or a segmentectomy, is non-inferior. So let's look at those trials. So this is a very old trial published in 1995 by Ginsberg, also from the Lung Cancer Study Group. But this very old trial that ran in the 1980s randomized patients with suspected clinical T1 tumors, so 3 centimeters or less, as seen on a chest x-ray, if you can believe that. And these patients were randomized to a lobectomy versus a sublobar resection, so either a segmentectomy or a wedge resection with at least a 2 centimeter margin. And the trial showed that there was significantly worse local control with a limited resection. So if patients had a sublobar or a limited resection, such as a segmentectomy or a wedge resection, the risk of local recurrence was up to 3 times as high as compared to with a lobectomy. The lung cancer-related mortality was around 50% higher with a sublobar resection as well. And so this Ginsberg trial really failed to demonstrate that a limited resection is non-inferior, and lobectomy was thus deemed the standard of care for early-stage non-small cell lung cancer. And for many decades thereafter, lobectomy has really remained the standard of care for early-stage non-small cell lung cancer. Of course, surgical techniques have improved a lot. Our imaging has improved. We're no longer just using a chest x-ray. We're getting CT scans on all of these patients. And our pathology assessments have improved as well. So a lot of improvements since the mid-'80s when this study ran. And so finally in 2023, there was this new study from the Alliance group that compared lobectomy versus sublobar resection specifically for patients with tumors less than or equal to 2 centimeters, as seen on a CT scan. And these patients had to have either presumed or biopsy-confirmed non-small cell lung cancer. And in this Alliance study, in the modern era, we find that sublobar resection was actually non-inferior in terms of overall survival, disease-free survival, and local regional recurrence compared to a lobectomy. So the 5-year disease-free survival was around 64% in both arms. The 5-year overall survival was around 80% in both arms. And the 5-year rate of recurrence was around 30% in both arms. And over half of the recurrences that happened were actually distant failures. So there was, of note, a small but significant decline in the FEV1 and the FVC after patients underwent a sublobar resection compared to a lobectomy. So it was just around, 2%. However, the authors noted that this might be clinically meaningful for patients that have compromised lung function. And so, if possible, and if we can spare patients from having to undergo a complete lobectomy, especially if they have compromised lung function, a sublobar resection is non-inferior in the Alliance trial. Now, one could argue you can also just give SBRT just as easily, which I definitely think is fair. But it's important to realize, a sublobar resection, so wedge resection or segmentectomy, is non-inferior to lobectomy for early stage cancers that are less than or equal to 2 centimeters in size. So I don't mean to do surgery dirty by skipping over probably 30 years of data that has, there's definitely been studies in between the Ginsburg trial and the Alliance study. But I, want to focus the majority of this talk on focusing on the radiation trials. But I did just want to mention kind of the two trials that I think are the most important that we should know from a surgery standpoint. And so remember that Ginsburg trial historically established lobectomy as the standard of care if we were going to be treating early stage non-small cell lung cancer with a surgical approach. But this more modern Alliance study tells us that for tumors that are less than or equal to 2 centimeters, a sublobar resection is non-inferior. So that can be a segmentectomy, which is kind of a more anatomical resection, or it can be a wedge resection, which is, just kind of removing the tumor with a margin. And the NCCN guidelines state that if we're getting a wedge resection, the size of the negative margin should be at least 2 centimeters. But if the tumor is less than 2 centimeters, then it should at least be the size of the tumor that was removed. And whenever possible, the NCCN guidelines also advocate for a VATS approach, so a video-assisted approach, just because this is less invasive, associated with decreased pain and improved return to function, fewer complications. So we want to be trying for minimally invasive approaches whenever possible. So now that we understand what type of surgery these patients should be getting, let's talk a little bit about which patients that go for surgery should be getting systemic therapy. So the older trials that first came out guiding our management in terms of systemic therapy really focused on adjuvant systemic therapy. So adjuvant chemotherapy followed by surgery. And then immunotherapy came out, and then we actually thought, what if we give the immunotherapy up front? So what if we do upfront chemoimmunotherapy in the neoadjuvant setting and then go for surgery? And so in the modern era, that's really what we do is typically we go for neoadjuvant chemoimmunotherapy followed by surgery. And the patients that are candidates for systemic therapy, think stage 2 patients. So patients that have tumors that are 4 centimeters or larger, as well as patients that have node positive disease. These are really the patients that we think about for systemic therapy. The LACE pooled analysis is pretty old now. It was published in 2008, but this was a meta-analysis of almost 5,000 patients across 5 different randomized controlled trials that ran in the late 90s. And these 5 trials all compared patients that had surgery for early stage non-small cell lung cancer and then either received post-operative cisplatin-based chemotherapy or no chemotherapy. And I said early stage, but they actually had stage 3 patients as well. So technically it was both early stage and locally advanced. But some of the patients in the trial did get radiation too. So they had kind of a comparison of post-operative cisplatin-based chemotherapy versus no chemotherapy. And then they also had chemoradiotherapy versus radiotherapy alone. So it was kind of a mixed group of patients, varying in stage. Some of the patients got radiation, but in the LACE pooled analysis, what they were really looking at was the difference in endpoint for patients that got chemotherapy versus no chemotherapy. And in this meta-analysis, the results showed significantly improved overall survival and disease-free survival with chemotherapy, as you might expect. There was about a 5% absolute 5-year overall survival benefit from the chemotherapy, and the benefit really varied based on the stage and the performance status. As you might expect, the higher the patient's stage, as well as the better their performance status, the more benefit they derived from chemotherapy. And on subset analysis, they found that the greatest benefit from chemotherapy was really for just stage 2 and 3 patients. And so that's where we get that, greater than 4 centimeter tumor and node positive disease. For patients that were stage 1B, so think 3 centimeter tumors, there was not really a significant improvement. But when they looked at the overall cohort altogether, there was a significant improvement. But on that subset analysis, it was really the stage 2 patients and beyond that stood out. So the big takeaway from the LACE pooled analysis is that there is a survival benefit around 5% to adjuvant chemotherapy in patients that have stage 2 tumors, so 4 centimeters or greater or node positive. Stage 1B, I think, is a little bit of a controversial area. So if it's a 3-centimeter tumor, you might consider a referral to medical oncology, and they may take into account other risk factors such as the histology and things like that to really make an assessment about whether they need chemo or not. With stage 1A disease, so things that are measuring less than 3 centimeters, there's typically no benefit to adjuvant chemotherapy. In the modern era, the LACE pooled analysis is still very valuable to us because it tells us kind of who needs adjuvant therapy. But the adjuvant therapy that we are using is more personalized now, and we can actually kind of better target based on particular molecular features and biomarkers as opposed to just blanketly giving kind of the same chemotherapy to everybody. So in the modern era, if patients are not receiving neoadjuvant treatment, which a lot of patients will actually get neoadjuvant treatment, but if they're not getting any neoadjuvant treatment, then once they have surgery, we perform molecular testing on their pathology sample. And if they have a targetable mutation, we can give them a drug that targets that mutation. So for EGFR mutant patients, the ADAURA trial showed a benefit to 3 years of osimertinib. For ALK mutant patients, the ALINA trial showed a benefit to 2 years of alectinib. So targeted therapies that are approved for EGFR as well as ALK mutant tumors. There are many other tumors that we can test for. For example, the RET mutation, I believe there's an ongoing trial testing a targeted therapy for the RET mutation. So it's certainly possible that patients may qualify for particular clinical trials if they have other mutations present. And then if they don't have a targetable mutation, then we give them adjuvant chemoimmunotherapy. So chemotherapy for 4 cycles and then immune checkpoint inhibition typically for a year. So the EMPOWER-10 study was, I think, the first study that actually showed a disease-free survival benefit to the addition of atezolizumab to 4 cycles of chemotherapy. So this was for all patients, regardless of PD-L1 status. There was about a 7% benefit in disease-free survival for all patients. But then if patients had PD-L1 positive, so at least 1% PD-L1 expression, there was a more pronounced benefit to the immune checkpoint inhibition. So a 12% benefit to the disease-free survival. So we typically will give kind of a doublet chemotherapy, so a cisplatin-based doublet agent. And then they can also get immune checkpoint inhibition for a year. And then in addition to EMPOWER-10, that study looked specifically at atezolizumab. There's also been a Keynote study, Keynote-091, that looked at the same comparison but with pembrolizumab. And pembrolizumab prolonged disease-free survival as well. So now there's data for both atezolizumab as well as pembrolizumab. And EMPOWER-10 and Keynote-091, they were looking at immune checkpoint inhibition in the adjuvant setting, so after surgery. Checkmate 816 was the first trial that looked at neoadjuvant chemoimmunotherapy. So Checkmate 816 used the drug nivolumab, and they randomized patients that had stage 2 or higher non-small cell lung cancer to receive either neoadjuvant nivolumab with a platinum doublet chemotherapy or neoadjuvant platinum doublet chemotherapy alone. They did actually have a third arm that was ipilimumab and nivolumab alone followed by surgery, but it closed early. So Checkmate 816 really, in the end of the day, the 2 arms that they had were neoadjuvant chemoimmunotherapy or neoadjuvant chemotherapy alone. And what they found is that their primary endpoints significantly improved with neoadjuvant chemoimmunotherapy, so with the addition of nivolumab. So what were those primary endpoints? One of them was a 2-year event-free survival, and that went from 45% without the immunotherapy up to 64% with the nivolumab. And then the rate of pathologic complete response rate as well. So the PCR went from 2% with the chemo alone up to 24% with the chemoimmunotherapy. So significantly improved event-free survival as well as PCR rate with the nivolumab. They also had higher rates of radiographic downstaging as well as higher rates of R0 resection. So 83% with the nivolumab versus 78% without. So very important to know kind of the primary endpoints of Checkmate 816, the EFS and the PCR rates, and they significantly improved with the neoadjuvant chemoimmunotherapy. And their secondary endpoint of overall survival actually improved with nivolumab as well. So the 2-year overall survival went from 71% with the chemo alone up to 83% with the nivolumab and chemotherapy. And the ctDNA clearance was also higher with the nivolumab. And they found that there was actually no significant differences in terms of their toxicities or adverse events between the arms. So Checkmate 816, I think, is a really important trial to know because it was the first phase 3 study that supported neoadjuvant chemoimmunotherapy for stage 2 or higher patients, and it improved both their primary endpoints of EFS and PCR, as well as their secondary endpoints of survival and ctDNA clearance. Now, there have been many more phase 3 trials besides just Checkmate 816. So we have the Keynote 671 study that actually gives us phase 3 data for using neoadjuvant pembrolizumab and chemotherapy, followed by surgery, followed by adjuvant pembrolizumab. So they give kind of perioperative systemic therapy with this trial. The Adjuvant study is another trial that has a study design very similar to Keynote 671, but the Adjuvant study uses durvalumab. So they give durvalumab and chemotherapy before surgery, and then more durvalumab on the back end after surgery. And then the Checkmate 77T trial uses a very similar approach, but with perioperative nivolumab. In the modern era, many more patients are undergoing kind of neoadjuvant systemic therapy, and they might get adjuvant immunotherapy after. One thing that I think is really important for us to realize as radiation oncologists is that on all of these trials that looked at giving neoadjuvant chemoimmunotherapy, the goal of neoadjuvant chemoimmunotherapy was not to make patients that are very locally advanced and unresectable up front. The goal was not to convert them to a state where they can be resectable. And so that's something that we have to be very careful about, and something we'll talk more about in our next talk on locally advanced cancer. But keep in mind that with the neoadjuvant approach, there is a danger of patients sometimes not making it to surgery at all. And then at that point, they end up getting chemoradiation, and then we've kind of overtreated them, because if we just gave chemoradiation followed by adjuvant immunotherapy, that's sort of a standard of care as well. And so it's something that we just need to be cautious about, and why we need to be aware of these trials so that we can kind of engage in tumor board discussions and make the appropriate kind of treatment decisions for our patients. So the big takeaways regarding systemic therapy in the context of early stage non-small cell lung cancer, the indications for systemic therapy with surgery really go back to that lace-pooled analysis, and patients with stage 2 disease or higher are really the patients that benefit most from systemic therapy. So indications are tumor greater than 4 centimeters, so that makes a patient T2B or stage 2A, or patients with node positivity, so N1 can make you stage 2B if you have T1 to T2 tumor and you're N1 at stage 2B. Stage 1B, so T2A tumors, this is a more controversial space, and this is where we can kind of refer to medical oncology to incorporate factors such as grade and histology and kind of make that decision. But I think the textbook answer is stage 2 disease or above, so 4 centimeters or greater, or node positive are patients that get in some type of systemic therapy. Historically, these patients were undergoing adjuvant systemic therapy, and that still applies if we are not giving them any neoadjuvant therapy. So if they go straight to surgery and then they're found to have stage 2 or higher disease, then we'll treat them with that historical standard. So if they're ALK mutant, we'll give them alectinib. If they're EGFR mutant, we'll give them osimertinib. And if not, we'll give them an ICI plus a platinum doublet chemotherapy. And I don't fully know what medical oncologists are doing in terms of the immune checkpoint inhibition. I think a lot of them favor adding it for anyone, regardless of the PD-L1 status. But the greatest benefit is really for patients that have a PD-L1 of 1% or higher, and they derive a greater benefit. That's just something to know. And so that is sort of the approach to adjuvant systemic therapy. And then if patients are undergoing neoadjuvant systemic therapy, we give them 4 cycles of platinum-based doublet chemotherapy with immune checkpoint inhibition, and then these newer trials also give evidence for giving additional immune checkpoint inhibition after the patients have undergone surgery. So it's kind of a perioperative approach. And so I think those are sort of the major takeaways for systemic therapy. You should understand who gets systemic therapy and then a little bit of background about that data. I created a little cheat sheet for myself with the names of the various systemic therapies for non-small cell lung cancer, as well as their brand names, just because the brand names are sometimes used in clinic and it can be confusing if you don't know what they are. So I just made this cheat sheet so that I can sort of keep them straight. Remember, in terms of the targeted therapies, the most important ones to know for in the early stage setting are osimertinib and alectinib. Osimertinib or Tagrisso is an EGFR inhibitor, and then alectinib or Alecensa is an ALK inhibitor. Lorlatinib is also an ALK inhibitor, but the data for lorlatinib is really in the metastatic setting. So for the early stage setting, just remember osimertinib or alectinib. In terms of the immune checkpoint inhibitors, there's a lot of them. So atezolizumab and durvalumab are the PD-L1 inhibitors. The brand name for atezolizumab is Tecentriq and durvalumab is Imfinzi. So these are PD-L1 inhibitors. And then for pembrolizumab and nivolumab, these are the PD-1 inhibitors. So pembrolizumab is Keytruda and nivolumab is Opdivo. Now remember, PD-L1 is what is expressed by the cancer, and PD-1 is the receptor that is on our T cells. So that's sort of the difference. The mnemonic that I've made to kind of remember which ones are PD-L1 inhibitors versus not is add the L. So I just remember AAD, add the L, and the AAD immune checkpoint inhibitors are the PD-L1 inhibitors. So atezolizumab, avelumab, and durvalumab. AAD, add the L for those ones, and you know that those are the PD-L1 inhibitors. So atezo, avelumab, and durvalumab. That's sort of my silly mnemonic to remember which ones are PD-L1 inhibitors. And so finally, now that we're 22 minutes in and we're done talking about surgery and systemic therapy in the context of surgery, we can finally start talking about radiation for early stage non-small cell lung cancer. So most patients with early stage non-small cell lung cancer that have tumors less than or equal to 5 centimeters with no positive nodes, these patients are usually eligible for ablative radiation. And when we say SBRT, we typically in the US are referring to radiation regimens that are anywhere from 1 to 5 fractions. But even if patients have certain features that make them not amenable to SBRT per se with 5 fractions or less, we can sometimes give additional fractions and still give them an ablative dose of radiation, and it can be a very effective treatment for their cancer, and it can cure their cancer. Now, SBRT and surgery have not been tested head-to-head in a randomized trial so far. There are ongoing efforts to do this, and there have been some attempts that actually were not successful. Those trials had poor accrual, but there is an ongoing study, and we're trying to test this in a randomized fashion. But for now, we don't have evidence that SBRT and surgery are, non-inferior to one another. For now, the standard is really to reserve lung SBRT for patients that are either not medically operable or patients who decline surgery. And so what I'd like to do now is talk about a string of trials, a lot of RTOG trials and different numbers that you'll need to memorize. But these are various trials that kind of investigated SBRT as a possible treatment and kind of the onset of using SBRT for treating lung cancers. And then we'll talk about kind of how this treatment has evolved and how we use it safely in the modern era. Before we had the technology to feasibly treat with SBRT, a lot of these early stage non-small cell lung cancer patients were treated with either dose-escalated, conventionally fractionated radiation or chemoradiation. And based on some retrospective data, the local control rates in these patients was around 70%. Dr. Timmerman was really a pioneer of SBRT, and he led this trial, RTOG-0236, which was the first multi-center prospective trial of lung SBRT in early-stage non-small cell lung cancer patients. So they recruited patients with biopsy-proven non-small cell lung cancers who were not candidates for surgery, so they had to be inoperable. The tumors had to measure 5 centimeters or less, so we're talking about T1 to T2 tumors, and they had to be at least 2 centimeters from the proximal bronchial tree. The proximal bronchial tree, as we will learn, is a very critical organ at risk when we're thinking about lung SBRT, and the closer we are to those central structures, especially the proximal bronchial tree, the more fractions we want to treat with. In this particular trial, the dose that they were using was 60 gray in 3 fractions, and using such hypofractionated regimens, such a high dose per fraction, is kind of dangerous near those central structures. So importantly, in RTOG-0236, we're talking about peripheral tumors, meaning tumors at least 2 centimeters from that proximal bronchial tree, and the tumors were 5 centimeters or less. The way that these patients were treated, the GTV was drawn, and there was no CTV margin applied, so no CTV margin for subclinical spread. They went straight to the PTV. And in the modern era, when we're planning lung SBRT, what we typically would do is draw the GTV and then create an ITV on a motion study to account for the motion that happens as the patient breathes in and out. And if needed, we might apply gating if there's a lot of motion. However, in this particular trial, that technology wasn't necessarily there yet. And so these patients were treated with just a GTV plus a larger PTV margin to really account for that breathing motion as well as errors in setup as we normally do for a PTV. So the GTV to PTV margin was 5 millimeters in the axial direction and 10 millimeters in the craniocaudal direction. The margin was larger in that craniocaudal direction because if you think about it, as we breathe in and out, the lung tumors are more likely to move up and down. And the other consideration is that typically when we're treating with our fields, the fields are going to come in sort of on a horizontal plane. So they're going to come in kind of in that axial plane. So if there's any place where we would miss, it would be in the craniocaudal direction. So add a little extra margin in that direction. So that larger PTV margin was added, and then these patients were treated with 60 gray in 3 fractions delivered over 1 to 2 weeks, so over 8 to 14 days. So they had a few days break between each treatment. One important caveat for this dose is that in RTOG-0236, when they calculated the dose, they did not use any tissue heterogeneity corrections. So as we know, the dose attenuates differently when it's going through more water-based soft tissue versus the air in our lungs. So the 60 gray in 3 fractions did not account for that tissue heterogeneity, and a later analysis with tissue heterogeneity corrections actually showed that the actual delivered dose in this study was closer to 54 gray in 3 fractions. And so that's where we get that standard dose from, actually, of 54 in 3 fractions. In the modern day, if you were to treat with 3 fraction SBRT, 54 gray is the dose that comes to mind. And it's from RTOG-0236, which the trial stated 60 gray in 3 fractions. But once we account for that tissue heterogeneity correction, it's 54 gray in 3 fractions. So these patients were treated with the 3 fraction SBRT, and the primary outcome was tumor control. And they found a really good 3-year primary tumor control rate of 91%. The 3-year overall survival was 56%. The 3-year disease-free survival was lower at 48%. And it turns out that the primary mode of failure for these patients is still distant failure, but the local tumor control rates were very good at 91%. They later also published their 5-year local control rates, and it was around 87%. The rate of grade 3 toxicities was around 13%. The rate of grade 4 toxicities was just 4%. They did not see any grade 5 toxicity, meaning death. And their overall toxicity rate was around 25%, counting even non-protocol specified events such as skin toxicity, rib toxicity, and so on. So the big takeaway from RTOG-0236 is that patients that were treated with medically inoperable early stage peripheral non-small cell lung cancers with 3-fraction SBRT achieved a 91% local control rate at 3 years and around 87% at 5 years. So this, phase 2 trial showed a lot of promise in this space. RTOG-0236 was for patients that were medically inoperable, so not candidates for surgery. RTOG-0618 was the next phase 2 trial, again, that was led by Dr. Timmerman, that looked at the same exact dose, 54 gray and 3 fractions, this time, however, for operable non-small cell lung cancers. So this was a smaller study of only 33 patients, and they recruited patients with the same exact criteria. So early stage, less than or equal to 5 centimeter tumors located at least 2 centimeters from the proximal bronchial tree. But this time, the patients had to have adequate lung functions, and they had to be deemed surgically operable and medically operable. These early stage patients are typically surgically operable. It's really the medical operability that we're worried about, and they had to have been deemed operable by thoracic surgery. The treatment design was identical to RTOG-0236. Once again, it was 3-fraction SBRT. So in the modern era, that dose is 54 gray and 3 fractions. And they found that the primary tumor control rate at 2 years was 96%. They had 15% of patients that experienced grade 3 toxicity, but no grade 4 or 5 toxicity. So RTOG-0236 established SBRT as an option for patients with inoperable non-small cell lung cancers that were early stage, and then RTOG-0618 demonstrated really excellent local control, 96% local control at 2 years for early stage non-small cell, but this time patients that were medically operable. RTOG-0915 is another study. It's a phase 2 study that established 2 alternate dose fractionation regimens for lung SBRT. So this trial ran from 2009 to 2011, and they had the same eligibility criteria as 0236, so medically inoperable early stage peripheral non-small cell lung cancers. And this time the patients were randomized to one of 2 different regimens. So either 34 gray in a single fraction or 48 gray in 4 fractions given over 4 consecutive days. So no breaks this time. And the treatment, this trial was written, almost 7 years after 0236. And so slightly more sophisticated treatment design. So they used motion management study, and they employed either abdominal compression, gating, or breath hold for their motion management. And the PTV margins were made either using the same kind of conventional technique, such as in RTOG-0236, where they had a 5 millimeter axial and 10 millimeter craniocaudal PTV margin, or they did what we would probably do in the modern era, which is a 4D study, so a motion study, create an ITV to account for the motion, and then just add a 5 millimeter PTV margin to the ITV. So they had more sophisticated treatment planning. And the primary endpoint was grade 3 or worse toxicity at 1 year. And it was pretty comparable between both of the dose fractionation regimens. So around 10% with the single fraction and around 13% with the 4 fraction. And there were 2 grade 5 events, so 2 deaths, 1 in each arm. And the primary tumor control rate was around 97% with single fraction, 93% with the 4 fraction. So based on how the trial was designed, 34 gray and 1 fraction was technically deemed superior. However, both of the fractionation schedules met the pre-specified endpoints. And so this trial really just established 48 gray and 4 fractions, as well as 34 gray and a single fraction, as alternative fractionation schemes for peripheral tumors. So far we've established that lung SBRT is possible. There's various dose fractionation regimens ranging from 1 fraction up to 4 fractions so far based on the studies we've talked about. We've established that has very good local control rates with minimal toxicity. And all of the trials we discussed so far included patients with tumors measuring 5 centimeters or less that were located at least 2 centimeters from the proximal bronchial tree. So these are really what we consider peripheral tumors. The next few trials that we're going to talk about discuss SBRT for centrally located tumors. So starting with RTOG 0813, which I think is a little bit of a cautionary tale. So this was a multi-institutional study with the goal of determining the maximal tolerated dose in 5 fractions for centrally located tumors. So they included still tumors 5 centimeters or less that were this time within 2 centimeters of the proximal bronchial tree or immediately adjacent to the mediastinal or the pericardial pleura. The treatment technique was similar to RTOG 0915 that we just talked about, but this time they were using 5 fractions and they sort of incrementally increased the dose per fraction. So they started off at 10 gray times 5 fractions, so 50 and 5, and then they increased in 0.5 gray per fraction increments up to 12 gray in 5 fractions. So they gradually went from 10 times 5 to 10.5 times 5 to 11 times 5 up to 12 gray times 5 fractions. And these fractions were delivered every other day. They found that their primary endpoint was met, so they wanted less than 20% grade 3 or worse toxicity at 1 year, and they met that pre-specified endpoint, and 12 gray turned out to be the maximum tolerated dose with grade 3 or worse toxicity of 7.2%. However, there were 10 deaths within that first year. 4 patients in the 11.5 gray and 12 gray per fraction arms actually died due to severe complications, including esophageal ulcer and bronchopulmonary hemorrhage. So I think this is a cautionary tale because RTOG 0813 tells us that we need to be very, very cautious for these centrally located lung tumors. When tumors are located close to the esophagus, the proximal bronchial tree, or the pulmonary artery, it can sort of cause erosion of those structures and lead to ulceration or hemorrhage, especially things that are located next to that right branch of the pulmonary artery and the right mainstem bronchus. Those structures really touch there if you look at it on an axial CT slice. And so there can actually be erosion there, and then the pulmonary artery can kind of hemorrhage into the airway, and that can be really life-threatening and fatal. So I think the big takeaway here, this trial did kind of establish a safe dose for tumors that are quote-unquote central. So 50 gray in 5 fractions is a safe dose for tumors that are located within 2 centimeters of central structures, so either the proximal bronchial tree or any of those kind of central mediastinal structures. If it is a centrally located tumor, 50 gray in 5 fractions is generally safe. Now, few tumors in this trial were what we call ultracentral, and the definition of ultracentral is a little bit different because that is defined as tumors that are actually abutting central mediastinal structures, whether that's the proximal bronchial tree, the esophagus, the pulmonary artery, the pericardium, whatever that may be. If it's touching something in the mediastinum, it's ultracentral. And in that scenario, we have a couple more trials that we'll talk about. The first of those trials is the HILAS trial, which is a Nordic phase 2 trial for ultracentral lung tumors. So as we just talked about in RTOG 0813, they included tumors that were within 2 centimeters of the proximal bronchial tree. But there's clearly a difference between what is just central, meaning within 2 centimeters of the proximal bronchial tree, versus ultracentral, where it's actually kind of abutting structures that are in the center of the mediastinum. And so these ultracentral tumors clearly have a higher risk of high-grade toxicity because they can actually cause ulceration or erosion of those walls. So in this HILAS trial, they performed risk-adapted SBRT for tumors that were located within 1 centimeter of the proximal bronchial tree. So this time they were more central, so within 1 centimeter. They grouped patients into two groups based on the following criteria. So group A included patients that had tumors within 1 centimeter, specifically of the trachea and the main stem bronchi. And then group B were all the other tumors, so those that were within 1 centimeter of kind of the more branching airways, so the lobar and then the segmental. Trachea and main stem bronchi versus the kind of the lobar and the segmental bronchi. And the prescription dose was 7 gray times 8 fractions. So that is 56 gray in 8 fractions to the 67% isodose line. And that's another important caveat because the isodose line that they prescribed to was kind of much lower than what we typically prescribe in SBRT. So typically we prescribe to somewhere around the 80% isodose line, meaning that we aim for a hot spot on the order of around 120 to a maximum of 130% when we're doing lung SBRT. In this case, they were prescribing 56 gray in 8 fractions to the 67% isodose line. So you can imagine that that hot spot is much higher for this isodose line. The results of this study were that the 2-year local control rate was around 83%, and Arm A actually closed early due to toxicity. So grade 3 to 5 toxicity was seen in 22 patients in this study, and 8 out of 10 deaths that they saw were actually due to bronchopulmonary hemorrhage. So once again, the Hylas trial really tells us that we need to be very, very careful with these ultracentral tumors, especially if they're overlapping with the trachea or the main stem bronchi, because the pulmonary vasculature is right there just anterior to these vessels. And if we cause any kind of erosion there, these patients die of bronchopulmonary hemorrhage. So we need to be very, very careful with ultracentral lung tumors. The Sunset trial was published more recently. It was actually published within this year. And it also studied 8 fractions for ultracentral tumors, but they prescribed it in kind of a more moderate way. So the Hylas trial prescribed to an isodose line of around 67%, corresponding to a hotspot that exceeded 130%. In the Sunset trial, the hotspot was limited to 120% maximum. This study was designed with kind of a time to event continual reassessment, and they planned to start with 60 gray and 8 fractions, prescribed with a 120% maximum hotspot. So same dose as Hylas, but prescribed in a different way, less hotspot. So they wanted to start with 60 gray and 8 fractions and then kind of increase the number of fractions as they went along. However, the trial was actually stopped after that first arm of 60 gray and 8 fractions because they demonstrated the safety and efficacy of this regimen. So this trial included 30 patients that had ultracentral tumors, meaning they were abutting critical central structures, and they measured, they actually included T1 to 3 tumors, so they could have been a little bit over 5 centimeters too. And at 3-year follow-up, they found that the 3-year local control rate was 90%, and they only had 2 grade 3 or worse toxicities among their 30 patients. So this trial showed the safety and efficacy of 60 gray in 8 fractions for central and ultracentral tumors, especially the ultracentral tumors that are really abutting mediastinal structures. So we've talked about a lot of SBRT studies so far. As promised, a string of RTOG trials, and then the more modern Hylas and Sunset trials that are all looking at different dose fractionation regimens. And so we talked about various regimens: single fraction, 3 fraction, 4 fraction, 5 fraction, for kind of peripherally located tumors. As we get to that within 2 centimeters of the proximal bronchial tree, we start, seeing that 5 fractions was established by RTOG 0813. And then for tumors that are really central or especially ultracentral, meaning they're kind of touching or abutting critical mediastinal structures, we start to think about even more hyperfractionated regimens. So on the order of, at least 56 gray and 8 fractions, if not more. The last sort of couple of trials I want to just mention are trials that actually look at kind of clinically when we would use SBRT versus surgery. So those early RTOG trials kind of established that SBRT has very good local control for both medically inoperable patients as well as medically operable patients. So we start to ask the question now, can we treat patients that are medically operable technically and treat them with SBRT with the goal of avoiding surgery for these patients? Now, it turns out that this is actually really difficult to study in a randomized setting. And there were 2 trials that kind of independently started out, the STARS and then the ROSELLE trial. And they attempted to randomize patients to SBRT versus surgery and kind of compare outcomes. But it was very difficult to accrue to this trial, and both of them were actually closed early. So there was a pooled analysis of STARS and ROSELLE, which I'll go through here. And in total, it included 58 patients that were randomized to lobectomy versus SBRT. And the 3-year overall survival was 95% in the SBRT group versus 79% in the surgery group. And the 3-year recurrence-free survival was 86% in the SBRT group versus 80% in the surgery group. Now, the overall survival results seem kind of compelling, better overall survival in the SBRT group. The recurrence-free survival was not significantly different between SBRT and surgery. However, to this point, SBRT has not, this isn't really randomized data, first of all. It's kind of a pooled analysis from 2 independent randomized clinical trials that did not complete accrual. So it's not completely powered. And, at this point, SBRT and surgery are both treatment options. And per kind of the NCCN clinical guidelines and per standard of care, SBRT is recommended for patients that have either medically inoperable disease or patients that are candidates for surgery who refuse surgery. And so we can certainly treat with SBRT if patients wish to kind of defer surgery and not pursue the operative route. Now, there is an ongoing randomized controlled trial that will hopefully answer this question for us. It's a VA trial called VALOR. It's currently accruing. I believe they've accrued at least 100 patients, and their goal is 670. So that will certainly be interesting to follow. But until we have kind of level 1 randomized evidence, I don't know that we would be kind of changing that standard of care. Currently, what you should know is that SBRT is an option, and it's kind of reserved for patients that have either medically inoperable disease or patients that refuse surgery. So all of these early stage non-small cell lung cancer patients should really be evaluated by a thoracic surgeon, and they should also be evaluated by, I think, a radiation oncologist, ideally in a multidisciplinary setting. So once again, just to briefly summarize everything that we've talked about so far when it comes to SBRT, we talked about several studies that looked at SBRT fractionation regimens and established kind of safe fractionation schemes for different tumors. And what you'll find is that in practice, as the tumors are more and more peripheral, we feel more comfortable with fewer number of fractions. As the tumors get more central, especially as they start abutting critical structures in the mediastinum, we start to think about at least 5 fractions, if not more. Typically, if they're abutting critical structures, we opt for 8 fractions, and then there are also 10 fraction and 15 fraction regimens and things like that. So we really take into account the size of the tumor, the location of the tumor, and we have many different options for dose fractionation schemes. And again, once again, based on the data that we've talked about, SBRT is really a standard for inoperable lung cancer. And for patients that are medically operable, it can be an option for patients that wish to avoid surgery. Now, I did sort of mention, there were studies that kind of compared SBRT versus just conventionally fractionated external beam radiation and showed that SBRT has improved local control, and some studies showed similar local control but improved toxicity with SBRT. And so really SBRT is the preferred option when we're treating with radiation for early stage non-small cell lung cancer. There's a nice ASTRO guideline for early stage non-small cell lung cancer, and I don't want to kind of read through everything because I think it would be a lot to absorb. But there's a table here for your reference, and you can always kind of go and look up the actual ASTRO guideline for early stage non-small cell lung cancer. I think it has nice points about who should we be thinking about SBRT for medically operable versus medically inoperable patients. I think a very important point from this guideline is that for tumors that are centrally located, so think tumors within 2 centimeters of critical mediastinal structures, SBRT is appropriate, but the guideline does state that we need to use at least 4 to 5 fractions, no 3-fraction SBRT, and really keep in mind the critical structure dose. For large tumors that are greater than 5 centimeters, SBRT can be conditionally recommended if it's not suitable for surgical resection. And keep in mind, we don't have to stop at 5 fractions. We can give additional fractions and kind of spread the dose out over more fractions if the tumors are really large and we're worried about toxicity. A lot of times in practice, we may encounter early stage non-small cell lung cancer patients that are either not candidates for biopsy or don't want to undergo a biopsy. And this is something I've seen a lot in clinic. At that point, we really need to use our best judgment. And the guideline does say that SBRT may be considered in these patients. It's best to discuss these patients in a multidisciplinary fashion and make sure that they have appropriate imaging studies that really support a cancer diagnosis. So a PET scan that shows avidity, multiple scans over a series of months that kind of show proof of growth of the lesion. Sometimes we can consider those patients for empiric SBRT, even in the absence of a biopsy. I've also been talking a lot about central versus ultracentral tumors, and I just wanted to take a moment to kind of pause and discuss the definition of central versus ultracentral tumors. So the definition of these has kind of varied a little bit. RTOG 0213 versus RTOG 0813 actually did have slightly different definitions of what was considered central. The more comprehensive definition, which I think is the preferred definition, comes from the IASLC committee. And this is kind of an international committee on lung cancer. And the definition is a tumor that is within 2 centimeters of any mediastinal critical structure. So in this image here, you see the 2 centimeter zone kind of drawn out in a coronal as well as an axial plane. And that is, quote unquote, kind of the no-fly zone. So a lot of these trials that we talked about specified within 2 centimeters of the proximal bronchial tree. Well, the IASCLC committee definition actually expands that and says not just within 2 centimeters of the proximal bronchial tree, but really any mediastinal structures. So that includes the esophagus, the aorta, the pulmonary arteries, the heart. And I think that is really the preferred definition. So tumors that are kind of within that 2 centimeter line that end there but are not completely adjacent to a mediastinal structure, these are central tumors. And typically we think about kind of 5-fraction regimens for those tumors. Tumors that are directly abutting, meaning that your PTV is definitely going to overlap with a critical structure. Those, I think, we think about even more fractions. So 8 fractions, or in some cases, even 10 fractions or 15 fractions. And then just to reiterate, here are some of the acceptable SBRT doses that we think about for early stage non-small cell lung cancer. So there is data that a BED, or a biologically effective dose of 100 gray or higher, is associated with better local control and overall survival. So whenever we're thinking about our dose fractionation regimen, we try for a BED of at least 100 gray, and that's assuming an alpha-beta ratio of 10. So the smaller number of fractions that we have available are, the smallest one is 34 gray and 1 fraction, and that corresponds to a BED of 149.6. This has been studied, and I know there are some institutions that are very, very comfortable with single fraction. I think it has its pros and cons. It may be especially convenient for patients if they have poor compliance, if they're coming from very, very far away. Single fraction, to be honest, is not something that I personally have seen used a lot, but I do know that there are institutions that employ it regularly. The dose fractionation schemes that I have seen used more are in the 3 to 5 fraction range for SBRT. And typically, 54 gray and 3 fractions has the highest BED of all of these regimens at 151.2. It's really ideal for peripherally located tumors because it has the highest BED. But of course, we know, once again, from the data that we went through and the ASTRO consensus guidelines, we do not use 3 fraction regimens for centrally located tumors. 48 gray and 4 fractions has a lower BED of around 105.6. This is something that I've seen used more, especially if tumors are closer to the chest wall. It just tends to reduce the risk of chest wall pain out at 6 to 8 months. So giving that additional fraction, 48 gray and 4 fractions rather than 54 and 3, it seems to decrease the risk of chest wall pain a little bit. So if there are tumors that are very close to the ribs or, like very laterally or posteriorly located in the lung, 4 fractions seems to be better. 50 gray and 5 fractions has a BED10 of 100 gray. And this is really what we consider for centrally located tumors. It's not safe if the tumor or the PTV are kind of overlapping with our critical central structures like the mainstem bronchi, esophagus, or pulmonary vessels. But if the tumor is within 2 centimeters of that kind of no-fly zone that we talked about, and you can create a PTV that's not overlapping with your central structures, then I think 50 gray and 5 is the way to go. And then finally, if there are ultracentral tumors, depending on the size of the PTV, depending on the degree of overlap with critical organs, there are other alternate options out there. So 60 gray and 8, like they used in Sunset. You can use 70 gray and 10 fractions. You can use 60 gray and 15 fractions. In the US, this is technically not considered SBRT per the insurance definition, but the same principles of planning and setup and everything still apply. So many different options for radiation doses for early stage non-small cell. Now we are almost at the end here. I just wanted to take a moment to make a quick note about the use of systemic therapy with SBRT. And long story short, there are multiple ongoing clinical trials, but currently it's really not the standard of care to add systemic therapy to SBRT for these early stage tumors. No prospective studies to this point have really evaluated the role of chemotherapy in this population of patients that gets SBRT for early stage non-small cell. It's not standard currently to add systemic therapy to SBRT for early stage non-small cell lung cancer. These were some of the ongoing trials looking at SBRT with immune checkpoint inhibition. So Pacific 4 is looking at SBRT plus durvalumab versus placebo, and then they have a separate arm for SBRT plus osimertinib. This one is active and recruiting. And then a couple other trials were actually suspended or closed early. So there was a SWOG trial, or NRG S1914, looking at SBRT with atezolizumab. There was also Keynote 867 SBRT plus pembrolizumab, but this trial was closed early, reportedly due to futility. And so it's really not standard right now to be delivering immunotherapy or any kind of systemic therapy with SBRT for these early stage patients. If we're treating patients with chemotherapy and they're getting radiation, it's typically chemoradiotherapy followed by maintenance therapy. So that's just something to to keep in mind, that there's not data here and the data in this space is evolving. If you think about it, I do think it makes sense because we saw in a lot of those studies that the primary mode of failure for these patients that were treated with local therapy, whether it was surgery or SBRT, the primary mode of failure was really distant failure. So some type of systemic therapy might kind of help with these patients. But again, data in this space is evolving. Right now, we are not giving any kind of immunotherapy or any kind of systemic therapy if we're delivering SBRT. That brings us to an end, then, of our discussion of the evidence base for management of early stage non small cell lung cancer. So, just to briefly recap the treatment paradigm, when we think about early stage patients, we first have to think about their medical operability. And for patients that are medically operable who want surgery, if they have stage 1 tumors, they can be candidates for either a sublobar resection if their tumor is less than or equal to 2 centimeters, or a lobectomy if their tumor is greater than 2 centimeters. But a lot of these patients can be managed with surgery alone. If patients have stage 2 disease, so if they have tumors that are 4 centimeters or larger, or if they have node positivity, they can be candidates for neoadjuvant chemoimmunotherapy followed by surgery. Or if they first undergo surgery, then we typically treat them with some type of adjuvant therapy, whether that is targeted therapy or chemoimmunotherapy. And then finally, for patients that are medically inoperable or who decline surgery, SBRT is an excellent treatment option for these patients, and it can be curative. Keep in mind that the SBRT dose fractionation really depends on the size and the location of the tumor. But even if we're delivering radiation in doses ranging from kind of 8 to 15 fractions, it can still be considered ablative. That is all I have for this talk. Thank you so much for your time and attention.